We present the case of a 58-year-old man with recurrent abdominal pain and incidental radiological evidence of a 70 mm cystic lesion of the uncinate process in communication with MPD, compressing the duodenum. The review of the images also revealed a suspected solid hyperenhancing component inside. Considering the presumed high-risk stigmata not clearly defined by the radiologist, and according to the size of the lesion, an EUS was scheduled for cystic fluid analysis and tissue acquisition. Using a linear echoendoscope and after passing through the pylorus from the duodenal bulb, we confirmed the presence of a multilocular cyst of the uncinate process near the head. Echoendoscopically, the cyst presented irregular contour and margins, with a portion completely anechoic, and a solid component in the proximal part. We moved then the second portion of the duodenum to strictly face the lesion and to visualize the uncinate parenchyma. The cyst expressed a microcystic component, similarly a grape bunch aspect, few peripheral macrocysts, and a central hypoisoechoic area suspected for malignancy, and an anechoic liquid portion. The size of the lesion was more than 3 cm, confirming this worrisome feature. In addition, a clear connection to the MPD was not possible to detect. To better evaluate the suspected solid component and exclude mucus inside the cyst, a contrast-enhanced harmonic session was done using Sonoview. We prepared a straight vascular access and we inject the entire dose of contrast and handled 5 mm of saline solution. At the arterial phase, the lesion presented an hyperenhancement with an homogeneous contrast distribution that prolonged also in the venous phase, with a just relative regression of intensity. This behavior is suspected for a solid mural nodule, excluding the mucus diagnosis, that usually has not an enhancement after contrast injection. Considering the lesion as a cyst, a 19-gauge needle should be the preferred route to execute FNB. However, according to the location and second duodenum, the prominent solid component, and the small amount of liquid, we modified our approach using a 22 cutting tip needle. We fastly punctured the liquid component, the aspiration was really slow, and we just collected 5 mm of liquid for the smear and cystic fluid analysis. And then we targeted the hyperenhancement area, obtaining a valid macroscopic on-site evaluation. Cystic fluid analysis revealed a high level of amylase and lipase. Carcinoembryonic antigen was in the range between 5 and 192 nanogram millimeter, so in a range that has not been reported with a strong diagnostic value. A reduced level of glucose is strongly suspected for viscous fluid-like mucus inside, as was confirmed at the smear. K-ras mutation was present and histology revealed high-grade dysplasia. In conclusion, we can say that even if the value of carcinoembryonic antigen was not in range, the morphologic and contrast aspects and the histology were quite clear for the intrapapillary mucinous neoplasia with malignant degeneration. That was our final diagnosis. A surgical consultation was then recommended according to the international guideline. This clinical case was prepared and presented during the WISE hands-on training in 2024 in Seoul. Thanks for the attention.